Now it is
Okay,
visible. You can make it somewhat zoom in so that we can able to see the content.
thank you. Okay, good afternoon. Thank you very much to the organizers for this invitation. My name is Almudena Chavez Guerra, and I have the honor to introduce you along with my colleague Denise Neri and the great support of Dr. Rosalina Vasquez Lopez, COVID-19, a hyperinflammatory disease, on the way to understanding this pathophysiology of this disease. As we all know, in December 2019, a series of cases of acute atypical respiratory disease occurred in Wuhan, China. It spread rapidly in that country and other continents until it was named by the World Health Organization on March 11, 2020 as a pandemic. At the beginning of the pandemic, this disease was considered a respiratory infection. As the research on the virus progressed, we have learned that the nature of this disease is more a multisystemic condition more than a respiratory infection. The principal hallmark on this pathology is the pro-inflammatory events that occur, such as the such as the cytokine storm, the disseminated intravascular coagulation, and the involvement of the renin-angiotensin system that cause this multi-organic dysfunction. As we know, the replication of this virus begins with the binding of protein S with AC2. The second step is penetration of the protein S with the membrane fusion, and the viral genome is transcribed into an RNA template. Subsequently, the assembly of viral proteins takes place together with the viral genome, and finally, the release of the virus with the capacity to interact and infect with new cells. This documentary research was conducted via online databases such as PubMed during the period 2019-2021, and the following keywords were used to generate the search, such as COVID-19, SARS-CoV-2, AC2, secondary hemophagocytic lymphohistiocytosis, ARDS, cytokine storm, pathophysiology, hyperinflammation, and multi-organ dysfunction. Starting with the pathophysiology of the renin-angiotensin system, we can understand the cardiopulmonary disease caused by COVID-19 infection. The renin is secreted by kidney. Then it cleaves angiotensinogen to produce angiotensin 1. This peptide is hydrolyzed by AC, producing angiotensin 2, and it acts on two receptors, AT1 and AT2. Angiotensin 2 binds AT1 receptor, promoting vasoconstriction and cardiac inflammation, reabsorption of salt and renal water, and stimulates pro-trophic and pro-fibrotic activity, as well as an increased tissue oxidative stress. Therefore, the effect of angiotensin 2 with AT1 receptor are detrimental. The AC2 enzyme works as a regulatory mechanism for this system, and because it can degrade angiotensin 1 into angiotensin 1-9 and angiotensin 2 into angiotensin 1-7. The angiotensin 1-9 binds to angiotensin 2 receptor and angiotensin 1-7 to the mitochondrial assembly receptor. The enzymatic attack of AC2 on angiotensin 1 blocks the production of angiotensin 2 and its undesirable effects, promoting a cardioprotective, antiatrophic, antifibrotic, anti-inflammatory, antioxidant, vasodilation, and hypertensive effects. As we know, AC2 is highly expressed in heart cells and in lungs, and it's correlated with cardiopulmonary damage. The proposed hypothesis indicates that after attachment of the virus, it internalizes with everything and its receptor, the AC2. This phenomenon would propitiate downregulated AC2 and a subsequent increase in angiotensin 2 with AT1 receptor effects. Therefore, we observe an inhibition of AC2 participation in the renin-angiotensin system and its protective effects, leading to acute lung injury and adverse myocardial remodeling. One of the effects of COVID-19 infection is the endothelitis and an immune thrombotic response associated with acute respiratory distress syndrome. The ACE2 receptor is widely expressed in endothelial cells, and recent reports show evidence that SARS-CoV-2 can infect lung endothelial cells, causing endothelial damage manifested as endothelitis. This damage is due to the viral infection and the endothelial response itself, both leading to severe endothelial dysfunction associated with apoptosis. Endothelial lung damage contributes to further exacerbation or amplifying tissue damage associated with ARDS. The possibility that COVID-19 can infect the endothelium that irrigates any organ and tissue opens the possibility for multi-organ damage and is most likely another mechanism that explains the complex pathophysiology of this disease. The systemic inflammation caused by the damage at the microvascular level and the abnormal activation of the coagulation system manifests itself pathologically as generalized small vessel vasculitis and extensive microthrombosis. There is evidence of a persistent inflammatory state in severe COVID-19 patients. The cytokine storm, mainly interleukin-6, could be associated with significant activation of the coagulation system, and at the same time, inhibition of the fibrinolytic system. This provokes endothelial damage to the lung and probably to the surrounding tissue. The exposure of the tissue factor and other pathways of the coagulation cascade may also contribute to hypercoagulation. There is a proposal that interleukin-6 plays an important role in the generation of hypercoagulation status and with disseminated intravascular coagulation. For this part, thrombin response induces the synthesis of interleukin-6 and other pro-inflammatory cytokines. There's also an association between COVID-19 cytokine storm, acute respiratory distress syndrome, and the secondary hemophagocytic lymphohistiocytosis. The SARS-CoV-2 infection exhibits features of systemic hyperinflammation. This event is part of the cytokine storm. The hemophagocytic lymphohistiocytosis is a hyperinflammation state modulated by T lymphocytes. The uncontrolled activation leads to this cytokine storm. The histopathological changes observed in the lungs of COVID-19 patients can be explained by the effects of the cytokine storm, which induces an increase in the synthesis of collagen and fibrin deposition, which will lead to an increase in alveolar membrane thickness. And also the macrophage activation syndrome generates the presence of inflammatory exudate in the alveolar space and the formation of yellow membrane. All these changes lead to the state of ARDS, characterized by alveolar collapse and areas of pulmonary atelectasis and hypoxemic respiratory failure, simultaneously with the ARDS picture associated with COVID-19 due to the infection and damage of lower airways, the terminal bronchi and alveoli. So ARDS causes severe impairment of gas exchange that will lead to severe dyspnea, hypoxemia, and impaired carbon dioxide secretion. Another important complication of COVID-19 is sepsis, that is defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. Although the infection associated with sepsis is mainly bacterial, there are also been cases of sepsis of viral origin. COVID-19 related deaths occurred due to disseminated intravascular coagulation associated with the sepsis and organic dysfunction. This virus has an extensive tissue distribution, causing a large number of pro-inflammatory cytokines to be released, promoting a systemic inflammatory response syndrome called SIRS, which accelerates the cell damage and death in the lungs, also in the liver, in the heart, kidneys, and glands, adrenals, which can ultimately lead to multiple organ failure. The clinical manifestations of organ complications caused by the virus, as well as post-mortem findings. On the right side of your screen, you can see two of the main consequences in the lungs: the pneumonia and pneumocyte damage, and the ARDS,
related to thrombosis. The postmortem findings in upper airways showed severe tracheal bronchitis, and in lungs there was observed diffuse alveolar edema, also alveolar hemorrhage and pulmonary embolism. On the bottom right, it was observed a distribution of a disruption of intestinal permeability that led to enterocyte dysfunction. Also, the systemic inflammation generated by the gut microbes can activate innate and adaptive cytokines into the circulatory system, resulting in the loss of intestinal barrier integrity. The renal manifestations were related to tubular damage because of the identifications of viral-like particles within podocytes, as well as glomerular lesion showing focal and segmental glomerulosclerosis in some cases. The postmortem analysis revealed diffuse acute tubular lesion and enlarged tubular lumen, flattened tubular epithelium, and interstitial edema. There are many neurological complications, but they can be classified in encephalitis and encephalopathies caused by hypoxia and inflammation, peripheral nervous system dysfunctions derived by neurosensorial perception disorders such as anosmia and ageusia, also including the Guillain-Barré syndrome, a post-infectious autoimmune disorder, and cerebrovascular complications associated with hypercoagulability, like ischemic strokes, cerebral venous sinus thrombosis, and intracerebral hemorrhage. As the postmortem findings, there were observed microthrombi, microinfarcts, and generalized microhemorrhages. And the heart also showed important manifestations, such as myocardial damage caused by the hypoxia and hyperinflammation, with identification of myocardial hypertrophy, acute myocardial infarction, hyperacute focal necrosis, or of cardiomyocytes in postmortem analysis. Chen 2020 stipulated the main clinical characteristics of 113 deceased patients with COVID-19. In this graph, we represent these findings, showing that 100% of the patients' deaths were caused by ARDS and sepsis. 77 were related to acute cardiac injury, 49% had heart failure, 51% had type 1 respiratory failure, 41% died due to shock, 40% had alkalosis, and 37% had hyperkalemia. It is reported that the appearance of cases of multisystemic inflammation state in patients with PCR positive and negative, especially in patients, pediatric patients, described as an overlap of toxic shock syndrome and the typical Kawasaki disease. The pediatric inflammatory multisystem syndrome, temporarily caused by SARS-CoV-2, is not like Kawasaki-like condition, but the hypercoagulation picture could be in the pediatric patient the most severe form of COVID-19 at that age. It is very important to dissociate COVID-19 presentation on pediatric patients to Kawasaki syndrome, because the misdiagnosis of Kawasaki disease could lead to over-treatment by health professionals. Our discussion is focused in further and future research to understand more detailed mechanisms behind the pathophysiology of COVID-19 in order to develop novel therapeutics and diagnostics tools and vaccines proving to be the solution to the COVID-19 problem. Our conclusions are based on all this evidence, so we can affirm that SARS-CoV-2 infection produces a hyperinflammatory state more than a respiratory problem caused by the disruption of endothelial cells associated with ARDS and the renin-angiotensin system detrimental effect that lead to organ dysfunction. Here is our literature section, cited section, and thank you very much for your time and for this extraordinary invitation.
Thank you, Dr. Almudena, for your presentation. Is anyone having any